Well, welcome everyone, and thank you very much for coming out tonight. My name is Suzanne Pichetti Johnson. I am the program manager for Avenues to Wellness. So a big thank you to the foundation for making this speaker series possible. Yes. I want to just say that we lost Jan Lamprich this week. And so now Margie and Jan are gone. Jan was a pillar of the foundation and the hospital for 65 plus years. So it's a huge loss, and it's the end of an era. So now I am delighted to introduce our guest speaker, Dr. Betty Lacy. She is a retired psychiatrist who now offers brain health coaching after a very personal experience of dementia within her own family. Please help me welcome Betty.
All right, well, gosh, it's so great to look at everybody. I feel like I almost know everybody here, so it's really great. Jim and I moved here to Ukiah in 1994 with our son Ross, who was 12 and he's now 43. So, and our cat Oliver, and was that Oliver, or was it Jim? Yeah, Oliver. See, I'm here because you're here. I want to know about memory, right, and what's going to really jazz it up, what's going to give us more memory cells. So we actually pinch ourselves every day. Do you guys do this? Because we live in such an incredible community. We live in such a beautiful place. And, you know, I'm just grateful. I find myself grateful every day. So I want to just thank you for coming, and we'll begin the dementia dilemma. First off, before I start into statistics, which was always my worst subject in school, a little brain teaser. So let's start first with a couple jingles that you might recognize. So let's see. Oh, how's this first one go? See the USA in your Chevrolet. Tricks are for kids, you silly rabbit. Good, wabbit, good. 2 extra points there. What was, plop, plop. Fizz, oh, what a relief it is. What's that about? Okay, so, and the final one, a little song we used to listen to every Sunday night as our family gathered for the television program that this was. Good. Okay, you all passed. Oh, what was the 4 boys' names? Do you remember? Os. Little Joe. Adam. And Michael. Michael? No, Michael. No, there were only 3 sons.
Really?
That was a trick question.
Mr. Cartwright.
Okay, you know, this is a subject that really I've struggled because I really want to bring some humor to it, because I hate just getting up and talking about number 1 here, statistics. Here's what we're going to talk about today. So, and hopefully we'll have some more laughs throughout this. Okay, so statistics, what are they? A little bit about my personal story, genetics and epigenetics, new developments, and changing the narrative from fear to hope. So that's our goals today. So let's talk about dementia and how we define it. Dementia is really problems, we think of it with memory and cognition, but it's just as problematic with our personality and our behavior. So when people start to have memory challenges and cognitive challenges, our personality changes, our behaviors change. So this is really important, and a lot of times we won't really notice this in our loved ones until we see some of those personality challenges. We don't recognize the memory challenges, mainly because of just what we just did. Long-term memory is intact for many of us until our 70s and 80s, and then we start to have some challenges with it. But short-term memory is where dementia really comes in. That's really the problem. But it's tricky, isn't it? Because if you're talking about memories, people are telling you their childhood memories and, their parents' memories, et cetera, and you're thinking, oh gosh, this person's really got it together. But then you ask them, what time is it or what the date is, and they're a little lost. So you can see kind of the tricky nature here that we're dealing with. So dementia is really a umbrella term. You hear the word used a lot, but it really is, there are many forms of dementia, really probably 25 or 30. I have a group up here. Alzheimer's is the top one that we mostly hear about. It does make up about 60 to 70%. Alcoholism, vastly growing in our baby boomer population, folks. So we'll talk a little bit more about that. I just finished my newsletter, matter of fact, talking about alcohol in the brain, which you can go on my website and get. But alcoholism is huge right now. Vascular dementia, also called small vessel disease, is a problem that's often combined with cardiovascular problems or hypertension. And next off, we have frontotemporal dementia, which also has a genetic component like Alzheimer's, which we'll be talking about. And Lewy body and Parkinson's disease, also a component of dementia in all of these neurodegenerative diseases. The last form, mixed form. So what's interesting now is, as researchers have discovered, that it's not so clear cut. It's not like you have Alzheimer's or you have vascular or you have this. You could be like my father. My father was a physician, but he developed alcoholism later in life. He also had vascular components to his dementia because he had hypertension. And he also was at risk because he carried the gene that we're going to talk about for Alzheimer's disease. So dementia statistics, let's begin within the room. Could everybody raise their hand if you've had a family member with Alzheimer's disease or dementia? Okay. Leave those up if you can. Give you a little strength training here. Back there. I know it's tough. And next off, if you have a friend who's had dementia. Okay. Next off, if you know somebody in the community with dementia. Okay, keep your hands up. And finally, if you know somebody who is a caregiver for a person with dementia. Okay, just take a look around, everyone. I don't think there's a single hand that isn't raised. Is there somebody who hasn't raised their hand? Right there. Okay, amazing.
It's not in my family.
Yeah, and do you know anybody though with dementia?
Not really.
Really? Do you?
Is that one on each side?
Okay. I'm glad we can have a sense of humor. It is really important. Okay, so as I said, statistics aren't my thing, but I will say that, almost 7 million people in the United States have dementia, 55 million worldwide, diagnosed every 3 seconds. I think the most important here is that 2/3 of people with dementia are women. So a lot of people don't know that, but women, we have more sensitive brains and we are at greater risk for a lot of reasons. And we'll go into some of that. Let's see. Oh, and Maria Shriver, who's one of my heroines in the Alzheimer's movement, she has a platform called Women's Alzheimer's Movement, WHAM. I love the acronym. And she says with 2/3 of women having Alzheimer's, or 2/3 of people with Alzheimer's are women, why isn't everybody talking about that, right? Because that's really what's happening here, and why I'm so glad everybody's here tonight, is this is the pandemic that really none of us are talking about. And that's why it kind of goes underground. And why do you think that is?
Embarrassment.
It's embarrassment. It's fear. It's also worry. Could it come for me, right? So dementia is happening. It's here, it's in the room. And why is it here? Why now? Any ideas? I know Suzanne said don't talk, but you could talk now.
Environmental toxins.
Environmental toxins, definitely one. Other reasons that dementia could be problematic?
Maybe diet?
Diet could definitely be one.
Stress.
Stress, a big one.
Oh, yeah.
Other reasons? You're missing the biggest one, though.
Living longer.
Yes, getting old. Yeah, were you going to say something, Rhonda? Yes, age. It really is, we are an aging population, us baby boomers, right? That is the big problem. So in Dale Bredesen's book that came out in 2018 called End of Alzheimer's Disease, is looking at what are the root causes, and you all have already named some. So I'm appointing all of you, many of you read my newsletter, and I say hello to brain body health citizen scientists. We are all citizen scientists in this. I was just talking to Claudia, where are you, Claudia, the naturopath there, and we're just saying, this is a conversation that we all need to have, and we all, as citizens, need to be aware of the risk of this very serious disease. Dale Bredesen came up with these 5 reasons that are very, very significant, and these are all part of aging. So insulin resistance is one, inflammation is another, increase in clastic activity and decrease in blastic activity. Now what the heck does that mean? Well, these are really more medical terms, but essentially as we age, we're breaking down tissue. Anybody notice it's kind of harder to gain muscle? Really hard. I'm working on it, but it's not happening as like it used to. And because our breakdown is happening, our metabolism is less robust than it used to be. Case in point, Jim and I were looking out the window day before yesterday. It's 50 degrees outside. Here's these 10-year-olds, short sleeved, shorts on, riding their bike. We're inside, 69 at thermostat is set, with our scarves and our puffy vests on. So anyway, just an example that, things are changing, right, as we age. So toxins, yes, toxins is a big one. Chemical toxins, think of the fires. Also, we have research to support that people that live near highways or freeways have an increased risk of dementia. We also know there's biological toxins, things like mold. Some people are mold sensitive. And finally, there are physical toxins to the brain, such as TBIs, traumatic brain injury, football, soccer, hits on the head, etc.
Sorry, but I kind of suspect plastic too, and it's everywhere.
Plastic is huge right now. Yeah, that's a big thing. That's going to be coming up. And I was just saying to Claudia, since we're both in this field, that, and I should have prefaced my talk with this, is that everything changes. So everything I say tonight, there might be, the news article in the AP Press coming out tomorrow saying, no, this has changed. Because why? This is science. This is how science changes, right? So just a little preface there. So synaptic dysfunction is the final one, and that has to do with lack of hormones. Also, nutrients. Our food is often less nutritious, less nutrient dense, we like to say. And then also genetic factors, which we're going to go to. But before we do that, I'm going to tell you a little bit about my story. Let me introduce a few. So these are all family members who have passed away from dementia, mostly Alzheimer's type. But as I mentioned, my father over here on the right had a mixed form of dementia. He was ill for about 10 years and passed in 2020. My mother, we moved her up here. Some of you, I think, might have had an opportunity to meet her. Yes, Pat did. Renee, I don't know if you met my mom. Ellen did. I would bring, Cynthia did. Yes, definitely, to bring her to our youth group and to a couple art openings. My mom was a really wonderful person. And speaking of dementia, just how tricky it is, that, people would meet my mom because she was very social. And she would say, yeah, hi, how are you? And she had all the things. And then about a couple minutes later, I'd see this look over, and they would go, okay, things aren't fitting, right? But anyway, wonderful, wonderful person, my mom. This is her mother, my tiny nanny, up in the corner left. Tiny because she was tiny, tiny nanny, right? And then her husband, Isaac Newton Evelyn, he always dressed just like this, literally. Wingtips, shined, had the shiny shoes.
Was he tiny too? He looks kind of
No, he wasn't tiny,
He was
no.
just tall, just thin?
Yeah, just thin, yeah. And he always carried butterscotch, those butterscotch candies, and then when we would go for walks, he would hand them to me. And this is my paternal grandmother, Hi Nanny, because she was tall. And she actually used to make my favorite dish called baby limas and ham hock. Very popular in Louisiana, which is where she was from. Next off is my great-grandmother. This is my mother's grandmother, Amelia. And my mother recalled stories about Amelia Mottesneal when she was a teenager that the police would bring home her mom.
Oh, wow.
And because she couldn't find her way. She had dementia, and my mother remembered that. Oh, and then next off is my mother's brother, Uncle Tommy. So all these people have passed due to dementia. Now you would think I would know as a physician that something was wrong. But, I didn't get any education about neurodegenerative disease in medical school in the 80s and very little in the 90s in my residency, even though I was a psychiatrist. My wake-up call began when my mother became ill. And then I started to piece together the story. I have multiple family members with Alzheimer's disease. What's going on? And then what happened? Fear. Fear happened. After fear, anger. I was so pissed off. Why was I pissed off? Because the narrative, predominant narrative, was there's nothing you can do. Our friends, our family, my mother's care was at an academic center in the state of California, a UC system. Nothing you can do. Did they recommend genetic testing for us with a family history like this? No, that wouldn't be a good idea because there's nothing you can do. Okay, so I got pissed off and I said, gosh, something's happening here and I'm going to find out what's going on. So luckily I have a medical background, so I started delving into the research, and sure enough I found a gene that causes late onset Alzheimer's disease. And I decided at that point that I wanted to be the first woman in 4 generations to not get this horrible disease. So that's why I stand before you. I'm going to ask you to save your question just to the end.
I will go remember.
Yeah.
That's all right.
Okay.
I'll write it down.
Write it down. Thank you. Thank you. Okay, so what is that gene then that I discovered? Not I discovered. It was discovered actually in the 80s. It's called the APOE4 gene, and it is a gene that has over 200 interactions in the body. It's a cholesterol-carrying gene, so those of us that have this gene actually tend to have high cholesterol. We tend to hyperabsorb. It's thought that this gene actually allowed us to progress in our evolution. So that's kind of fascinating because we hung on to the fat. So in periods of famine, we were robust. Our APOE4s, like me and my family, would have been robust. The problem was, as we got older, the gene worked against us. It increased things like inflammation that we were talking about as one of the root causes, and other problems with our metabolic health, like our lipids, and then made us more prone to cardiovascular disease and then to neurodegenerative disease the longer that we live. So now we know, though, we have about how many people do you think, Suzanne? 45?
About 50.
50.
Yeah.
So about a quarter of people in this room will have this gene. Okay? You don't know it, you can't feel it, right? It's no different. But about a quarter of people will have this gene. And now we're discovering that old narrative, there's nothing you can do. There's actually a lot you can do even with this gene. And that the results now are showing in a new study that it's called the REVEAL study, when you find out that you have this gene, like me, you actually become more proactive. Mm-hmm. So now anybody that comes into my program, I pretty much recommend that they test for this gene, because my hope is that then they will become more proactive. And indeed, I don't know if people are familiar with Peter Attia. His book Outlive has been on the New York Times bestseller all of 2024. And he actually believes everybody should be tested for this gene early on in their 20s or 30s to know that they're at risk, not only for neurodegenerative disease, remember, this increases inflammation in all of your vasculature. So many people might have had a family that didn't look like mine, but they died early of cardiovascular disease. They probably or possibly might have been carrying this gene. Okay, we are finally the canaries in the mine, so we're sought after by any of the research studies because if we improve, right, with the research or things that they throw at us, then we know the rest of you are going to improve. All right, and my brother's in a study currently, and my mother was as well. So that's it on genes. Epigenetics, because that's really what we're talking about here, with genes being the hardware. Epigenes, we used to say, remember nature versus nurture? That was a big thing when we were growing up. So nature is your genes, nurture is what you're doing in your environment. Now it's a whole phenomena and field of study called epigenetics. So, but we know that we can't influence, we can't change those genes, but we might be able to modify them. And as all poker players know, it's not the cards you're dealt, right? It's how you play them. So that's what we're really looking at, those of us involved in epigenetic and lifestyle changes. So I wanted to just show you, all of this is elucidated more on my website, but if you look back into the studies, really the first one that showed, in 2014, it was Dale Bredesen study, where he showed a reversal of cognitive decline in 9 out of 10 people using lifestyle modification and also supplementation with things like vitamin B12, vitamin D, different kinds of things, and monitoring those levels. So that was pretty cool when I found that. And then in 2015, Lancet, which is a very well-known international journal, that it actually showed that in a Finnish group of people that had actually an intervention group where they monitored their nutrition, they monitored their blood pressure, they monitored their weight, they monitored their lipids, their blood sugar, etc. And then a non-intervention group, they showed that that intervention group actually improved in their cognition. And the cool thing for me was a number of the APOE4s in that study actually improved. So I was like, okay, hands down, I'm in, okay? So then JAMA came out in 2019, JAMA, Journal of American Medical Association, right? So they came out and said, yes, healthy lifestyles may offer an offset of genetic risk, okay? So that's cool. Then in 2022, there was a revisiting of the NUN study. Do people know the NUN study? Yeah, Renee's shaking her head, yes. So the NUN study was super cool because this was a fellow named David Snowden, who was an epidemiologist, and he found that that the convent near him, he just became very interested in the population of sisters there because he felt like they thrived into an old age and didn't develop dementia. So he started to examine them and create a study, and indeed they all agreed to even have their brains autopsied afterwards.
Oh, great.
Now what was very interesting in that study is that despite some of the brains having lots of amyloid, because he was looking at their brains, that's the pathological feature of Alzheimer's disease, that some of those nuns actually were thriving. So this brings up, well, was there something in their community? Was there something in their way in which they were taken care of, stress-free, given meals, a pretty nice environment, right? And plus a lot of socialization, that they fared really well in their aging. And so they just revisited that study. That study was begun in 1986 and finished up in 2001. And so, but in 2022, just 3 years ago, they revisited it. And what they found is that the old records that actually the sisters changed. Like sometimes they would come in and have cognitive impairment. They would test them 3 months later, and they didn't have cognitive impairment. So what was happening there? You know, it's like, did they have a couple good days? Did they sleep better? Were they eating better? Did they exercise? Fascinating. So this is how things are changing, right? And finally, Dean Ornish, people might be familiar with him. He did the show that cardiovascular disease could be ameliorated with diet and lifestyle change. He's now changing and completed a small study for people with Alzheimer's and found very similar results, that yes, you could change with lifestyle. Not everybody improved, so that's the deal. It's not a slam dunk. You can't just change up your life, and like even me, I may get Alzheimer's disease, but I'm going to do everything I can, right, to be that fourth generation to not get it. Okay, so epigenetics, the earlier the better. Dementia is preventable. This is the big message tonight, right? Dementia is preventable, modifiable, and reversible, okay? So, and another really important point here is that, I don't know if you've heard of the term MCI, mild cognitive impairment. A lot of people are diagnosed with that these days. My brother was diagnosed with that. And if you have mild cognitive impairment, 15% of that population will progress to Alzheimer's each year. By the end of 5+ years, everybody has Alzheimer's. So if you get a diagnosis, or everybody raise their hand, knows somebody with dementia, if you get a diagnosis of MCI, then that should be treated with intervention. The problem with our current community in healthcare is that they diagnose it and say, come back in 6 months and we'll test you again. Really, that is the standard of care right now, right? So we have to change that, because I'm showing you research here that's saying we can reverse that. We don't have to hang out with it. The more that we hang out with that degree of change in the brain, it's just going to continue to get worse, right? What are the things that we can do? This is now combining genetics and epigenetics. This is the program that I've been working, and this is kind of the general program that I would say most people involved in brain health are recommending right now. So I'm just going to say a little bit about all of these. A lot of you know all these factors. Sleep, of course, is a huge factor. If you should be getting 7 to 8 hours of sleep a night. If you're not, that's problematic. The reason it's problematic is because you have these little janitorial cells that are white blood cells that migrate to the brain. They're called microglia. And they actually only work when you're getting that 7 or 8 hours of sleep, or those 4 stages of sleep and REM sleep. If you have a shortened sleep, your REM sleep goes down and those janitorial cells are not working very well. Next up, I like acronyms, so it's SLEDs, and I keep adding more things here. There's more S's, that's exactly right. So sleep, vitamin L, so vitamin S, vitamin L is learning, labs, and testing. So I can't tell you enough how we need to keep robust in our learning. So remember, I don't know if you remember this, but even when Dick Drury, he was a psychiatrist here ages ago. Did you know him, Jen? No? Okay, did you? Yeah, so anyway, he's a very well-known psychiatrist here. And he kind of mentored me, and he, when he retired, they brought out a rocking chair for him. And I'm thinking, if you bring me a rocking chair, I'm going to pull out I don't have a firearm, but I mean, it's like, that's the worst thing you could do for somebody our age, right?
So it was exercise.
Yes, right. Oh, right. Yeah, that's the big exercise. Yeah. No, that doesn't count. Keeping robust in your learning, about learning a new language, learning a new instrument. All these things are great, but you want to have a little bit of what we call hormesis. You want to have a little stress with it. Your brain's like a muscle, so you want it to work a little bit. So if you just know something really well and you keep doing it, good luck with that, because that's not going to improve, your synapses, right? Testing is super important. Many of us in brain health do pretty mega panels, I would say lots and lots of blood work. People come back saying, gosh, I don't know, I think I need a transfusion after all your orders, So But seriously, it's really good to check lots of different variables. Now we know that there's a lot of things that influence brain health, so it's important to know all those. Let's see, finally, mocha. So what's a mocha? It is a coffee drink, but this is not the coffee drink here. A mocha is the Montreal Cognitive Assessment Tool. Everybody should be having this at age 60 and at least once or twice a year. And so that's going to allow us to make an assessment of where you're at. It's a 30 question, can be done 15 minutes. The medical assistant can do it. You don't even need the provider to do it. And or you could even go online and look at the McCants brain scoring on your own. It's got 30 questions, similar questions in some respects, a little different. It will give you a score as to how well you're taking care of your brain. So all kinds of things are available, but that's a big one. Somebody asked me, he's not here, but at the piano concert, tell me the difference between normal aging memory and memory that is impaired. And this is where the rubber meets the road, is the testing. So that's how you can tell. So if you're wondering if you're having trouble, get in and get a mocha or see your primary care doctor. Okay, vitamin E, what can I say? You all know, is it important? Mm-hmm. How important?
Big time.
Big time. Thank you. Yeah. And you need to be having, again, hormesis, right? Need to be doing strength training and aerobic. Aerobic, you need to be doing 150 to 300 minutes a week. A week.
Oh, wait, thank you.
A week. That's 30 minutes minimum a day. Aerobic. Aerobic is what? It's not like this isn't aerobic. It's not aerobic. I'm not being aerobic right now, people. Okay, no. Aerobic is I can't hardly talk when I'm aerobic. That's aerobic. Okay? So, got to climb the Maple Hill or one of the other hills to get aerobic, really. Diet is huge. We talked about nutrient-dense food. That's really important. Organic, if you can. There's also always a list of what are the not organic but are free of majority of toxins. What do they call that? The dirty dozen and the something good dozen. I don't know, something like that. But anyway, you can look that up. Stress reduction. What can I say about this? I'd like to do some right now. No, I'm feeling good. But stress reduction is really huge. Socialization, one of the big factors for dementia is social isolation, loneliness, very, very big factors. So make sure you're in community. I will say a little bit to the guys in the crowd here that men, and they've told me this in my years as a psychiatrist too, once they retire, their social circle goes like this. Women go like this. Yeah. So, could be something in the Y chromosome. I don't know. But it's something to really think about, guys, for you, for men's health. And Jed's over there going, the men's health specialist right here. Sensory health. So I added this S just this last year. So this is sensory health. So eyes, ears, and sexual health. Really important. You should be having it. Just think about it in that synaptic dysfunction that we talked about. If you're not hearing and not seeing well, the synapses in the brain are literally getting less information, degrading, and basically dying. So it's very important that we all get our hearing tested about every 2 years and our vision, especially as we age, because it changes, right? Let's see, sexual health. So for guys, if you're having erectile dysfunction, that could mean that you're having small vessel problems. So it could mean a cardiovascular issue, and so it's really important that you get in and talk to your primary provider about that. For women, really important as we age, we're much more prone, men are prone too, but mostly women, for urinary tract infections. We were just talking about this with somebody else. And very, very common. And so we are looking at how hormone replacement, vaginal replacement can make a big change in reducing UTIs in women. So something to think about. Spirituality and purpose, what can I say? Having a sense of inner peace, however you want to do that, through prayer, meditation, and religion and non-religion, is absolutely paramount, I think, to growing old. It also allows us to answer deeper questions about ourselves and our life, and give us a sense of purpose. All these are very important. So sleds, something we can all do. Okay, hope. New developments. Now this is why I'm super excited, and this is what is changing the narrative further now. We're really pushing up. So science now has developed a blood marker for amyloid and tau. These are the two pathological substances found in the brain with Alzheimer's disease. So remember that's 60 to 70% of dementia. So imagine if you can go in and get a blood test. You don't have to maybe have an MRI. You don't have to have neurocognitive testing, which takes up a day's worth of. And where are you going to find a neurocognitive person, psychologist? Not locally, for sure. You're definitely going to have to go to Santa Rosa or beyond, or go to the UC system. So it's very costly, the workup for dementia. So if you could go in and start to differentiate what kind of dementia you had, this is going to change the landscape. If the test has already been released, it's just that our medical providers have to get on board again with some of these prevention and some of these ways of looking at these tests as an indicator, not as a negative. I'm going to get tested this year because I want to know. And people are saying, well, Betty, you already know your APOE4, you already know you're at risk, right? Why would you want to know if you have amyloid on your brain? I mean, don't you know enough already? And it's like, no, I want to know because then I can follow my amyloid levels and I can bump up my game more. So I can drop, and they've showed this, that you can drop your amyloid levels with certain lifestyle changes, One might be high intensity interval training. That's a new form of aerobics. So anyway, that's on the landscape, and we'll be rolling out, I hope sometime this year in our community here with your primary care providers. Ask them about this if you're interested. Ask them about getting tested for the APOE4. Ask them about getting tested for amyloid if you have a history, or even if you don't. Okay, monoclonal antibodies, you've probably heard about some of these MAB drugs, lecanemab, aducanumab, denosumab, you can barely say them, but they are the lab-engineered antibodies that actually are injected via IV into people, and they float up into the brain, they grab onto the amyloid, they cause clumps, they degrade it and excrete that. So that's they're very amazing. Problem is they're super expensive. And by expensive, I mean $30,000 a year. So, but Medicare is going to pay for some of that. We don't know exactly how much. That's really on the forefront. This is the first disease-modified medication. Up until this point, just in the last 2 years, we haven't really done very well with the acetylcholinesterase inhibitors. These are Aricept, memantidine. These haven't really done a lot. They might just make things a little bit easier for you. You can remember what pants are or something, but it's not really helping you overall. These are actually giving you at least another year of life without memory challenge progression. So that's pretty incredible. I'm going to hold that thought again. Diabetes. You've probably heard, right, that diabetes type 3, they're calling Alzheimer's now. Because there's such a relationship between diabetes, another huge pandemic, right, throughout the world, really. And it's guesstimated now that if we reduce the diabetic population, that we would reduce Alzheimer's by 50%, almost the same number. So that's pretty amazing. So right there it tells you one of the tests that we order on everyone is a blood sugar, fasting blood sugar, hemoglobin A1C, and your insulin. We want to know what your insulin is because your insulin will foretell if you're going to develop diabetes 5 or 10 years before. So you can take agency back, take your health care back, take note of some of these things and talk to your primary care provider about them. Hormone treatment is showing some very big improvements, particularly in those people with APOE4 like myself. It's actually shown to improve the hippocampal volume. That's the hippocampus is in charge of the memory in the brain. So that's pretty cool. Many people are saying now, in 2001 with the Women's Health Initiative study, 75% of women went off of their hormones. 75%. That study, we know now, was somewhat flawed. And so now we're really looking at that, and when you just think about the trajectory of Alzheimer's disease, that the disease begins 20 or 30 years before. If the average time that one ends up with memory challenge is 75, that's for men and women, go back 30 years and where are you? 45 to 55. What's happening to us? What's happening at 45 to 55? Menopause, right? Yes. So there's something going on there, right? So now we know that probably hormone therapy is somewhat neuroprotective. Now, is there a risk of breast cancer? It does look like, of course, that there might be a small risk. And again, these are things that you have to decide. For instance, my family, there's no cancer in our family, but I just showed you my slide up here, right? A lot of neurodegenerative disease, so I have a choice to make. Am I going to go on hormones, and because it might be better for Alzheimer's, or am I too afraid of getting breast cancer? Well, there is no cancer in my family. I'm not afraid of cancer. So I'm going to opt for the hormone therapy because I want to protect my brain. So everything's individual. And that's just an example of a decision that we all need to think about making. Healthcare needs to be individualized and precise. Right now, it's one size fits all. We really need to be thinking about that and take back our own, again, agency and autonomy with our own health. So hormone treatment, neuroinflammation is another new medicines that are being targeted for that problem. The CRISPR gene, I read a great book called The Code Breakers, actually chronicling the gene editing that's featured in CRISPR. It's actually already helped a number of people with sickle cell disease, where they actually edit out the gene that causes sickling of the cells in African American people, and it's made a huge difference. So imagine if I could go in and have some gene editing and the 4 would disappear for me. I wouldn't have an APOE4. That would be pretty amazing. I would sign up for that. Tismani tribe is a Bolivian tribe who's had no contact with the modern world. Somebody went down there, I don't know who, a journalist, and a scientist to study the tribe, and through their blood testing they discovered that a preponderance of the tribe, not just 25%, but almost like, I don't know the percentage, but let's say 75% of people had the APOE4 gene. Guess what? They don't have dementia. Why is that? Is that because in our modern society we have so much stress and so much toxins, chemicals, food problems, inequities, etc.? I mean, so I see some curiosity, and that's really what we want to do, is we want to be curious about these things. And finally, what's going to really happen, and what gives me hope, is that this is going to be about combination of many different therapies, lifestyle and genetic things and other kinds of medication. Much like AIDS, I went to medical school in Philadelphia during the HIV/AIDS epidemic. Philadelphia, the movie, right? That was right there, and that was a very, very powerful, very, very scary time for the vast majority of people. But we have a friend who's has HIV positive and never developed AIDS. Why? Because he got on these medications. So antivirals, again, a combination form of therapy. So hope is out there. Okay. So I hope I've given you some hope tonight. and hoping to change, again, that narrative of there's nothing you can do. Do you get the feel for there's a lot you can do? Everybody in here can do a lot, and the deal is to know what your individual risk is. I've told you a little bit about my individual risk, but then to assess your risk and to go at it by yourself or online. There's lots of resources now. APOE4 has an online group, over 1,000 members from around the world. So there's a lot of information out there. But it's the internet, right? So there's a lot of information. That's kind of the problem. Okay. So we're transforming our fear of dementia with science, right? It's always changing, support, sharing our stories. I told you my own personal story. I now see Alzheimer's disease as a teacher. I may get Alzheimer's disease. I may not be able to give this talk in another year or 2 or 3. But the way that I look at it is Alzheimer's has been an incredible teacher for me. And I think it's teaching all of us how are we going to deal with aging neurodegenerative diseases on many levels, on our inequities in health, how we live and die. I mean, this just has really big ramifications when you think about it. Early intervention is better. Also, don't let somebody just say you have MCI and see you in 6 months. Please do not do that. Combination therapy is the future of our healthcare for neurodegenerative diseases and dementia. And then finally, parachutes work best when they're kept open. Keep your hearts and minds open. And then my final slide, there's my mom and dad that I'm going to dedicate this talk to. Good, and I'm just almost out of my battery power, so that worked out good. Okay, thank you very much. We're open for questions.
What is your website?
Oh, brainbodyhealth.org. Yeah, and I have a newsletter there, just every month. I'm on Substack now too. Okay, yes, now.
I'm sorry, I have 3, because I was quiet.
Okay.
2 are quickies though.
Yeah.
They talk about early and late onset. Do you know kind of what they're talking about when they say early and late?
Good question. Yes, early is the genetic form. Both have genetic underpinnings, but the early form is only about maybe 1 to 2% of Alzheimer's disease. If you get one of the genes with the early form, you're going to get the disease, and you're going to get it earlier, usually in your 50s. Whereas the average, as I mentioned, age for Alzheimer's disease showing memory challenges is the average, again, would be 75. People do end up with earlier challenge.
Well, I think I'm going to skip one of my questions and jump, because that kind of speaks to my big question is, I was diagnosed with too many platelets. And I'm wondering about what they found in there is bone marrow cancer, which and in the old days, and I don't know if it's in my family or not, because I think they weren't able to see that before. But I think you said something about a correlation with Alzheimer's and some kind of platelets, or no, you didn't say.
No,
okay,
platelets.
wider.
Yeah.
Yeah, you did say
Yeah.
that.
Rhonda, yes.
Could you give us a quick review of what you do in your coaching sessions, how you help people?
Yes, I'm happy to. I'm a little full right now with my coaching clientele. I'm trying to figure out how to do that and maybe do some online things like this that I could open it up and have some questions or things like that. But I see people generally for 3 separate visits. Each are 90 minutes each. We go into a lot of detail historically, and for the first visit, I send them out with a mega prescription for blood work. They come back the second session, we go over the blood work, look at their risk analysis, so that's really what I'm doing, just kind of saying, okay, this is what your risk is. Your high risk, your medium risk, your low risk. And part of that, of course, would be an APOE4 gene test. And then the third session is to deal with also end of life, making sure people have advanced directives, and lots of interesting information. I just finished a course last night on Finish Strong by Compassion and Choices. That's been for 2 months, and it's been super fascinating learning about all the things that, again, we can have agency over our death with certain ways still in this country. because many of you, I don't know if you know this, but dementia is not considered a terminal illness. Even though it is terminal, it's not terminal within a 6-month span, and that's where medical aid in dying can happen. That's only happening in 10 states. Yeah, super challenging, but there are some things that you can do. So that's something I do with on the 3rd session. Yeah, thank you. Yes.
Is there any correlation between other mental health issues like schizophrenia or bipolar and Alzheimer's or dementia?
That's a really good question. I will say one of the genetic components that we know, people with Down syndrome are more likely to get Alzheimer's. So that's kind of sad. But yes, they will get that usually earlier. In terms of schizophrenia and bipolar, I will say with bipolar, what's very interesting is that there has been a book written about a gentleman who was a psychiatrist and also quite a scientist who studied people in the long term and found that people that took lithium had less problems with dementia. So people with bipolarism had less. Now, people with mental illness often, and I equate mental illness in the new term, brain disorder. They have a brain disorder. This is not something mental or emotional, right? This is a brain disorder. That people who have that are actually often challenged socioeconomically. So all of those SLEDs variables that we just talked about in the acronym that I use, that is, those are all challenged, you know what I mean, often for people with this disease. But we don't, we haven't tested that.
Right. And I also wondered about children of alcoholic parents with all the fetal alcohol syndrome, if that predisposes them as well.
Well, anybody with any kind of brain challenges would definitely have some predisposition because you're having basically less tissue, right? So and that is also very easily determined with a MRI or something as well. It is interesting. Size does matter with brains. So it's true. So the brain size, if you have a bigger, literally skull, that you have more brain tissue then that's going to fill that. And so it is interesting because, she's got a big head over here. That's good. No, I mean, there is something to that. I mean, it makes perfect sense, right? Yes.
Have you come across, I don't know anything about this, and I don't know where I read it, but it was a few months ago. Have you come across in your research reading about possibilities of some people who I guess they're getting biopsies who actually have an infection treated with antibiotics that can clear up, I'm not talking about a cure for Alzheimer's or anything, but in a certain number of people, they responded to an actual antibiotic course that cleared up their memory problems.
Well, that's very interesting. There are, a number of those situations. What I would say, one would be dental. So when people have, I didn't really mention dental, but dental hygiene is one of my questions when I'm doing this 90-minute, intake on people. We know that there are various organisms that can invade the blood-brain barrier. There's a very big brain barrier that keeps most toxins out. But that's where the microbiome now studies are coming in to look at when we actually have disruption in the microbiome, that those then toxins can go up and create little openings in the brain, so then more toxins or bacteria or viruses can enter. So yes, there's a whole field, right? And actually along these lines we've talked about amyloid a little bit. So there is the amyloid theory and this $20 billion, now more than that, search for the anti-amyloid, silver bullet, which there hasn't been one. But amyloid, it turns out, might be the brain's way of protecting itself when it has some kind of toxin or invasion. So it's really fascinating when you think about it. And also the Tsemi tribe that I mentioned in Bolivia, it turns out they have a lot of infections, parasitic infections. And they have found that maybe the fact that they've had those infections actually increase the brain's ability to actually keep toxins out, which is why maybe they don't have such a high rate of dementia that we do, despite having high APOE4s. So, yeah, I mean, I could definitely spend about 15 minutes on that question right there, yeah. Yeah.
Betty, I just wanted to point out, though, interesting about the change in perspective about amyloid being positive versus protective.
Yes.
And I think that we all have to keep in mind that when you're reading a piece of research, it's showing correlation between different factors. There's a high incidence of lithium use and a low incidence of Alzheimer's. It doesn't mean that taking lithium is going to prevent you from getting Alzheimer's.
Yes.
And so just keeping that in mind when you're evaluating research, I think is
Yes.
super important.
Thank you so much. Yeah, and same with observation studies. You know, when we're doing these big observation studies, the challenge in medicine, I mean, observation studies can be helpful, right? Random control trials of medication take 10 years to come to fruition, and they're very, very expensive. So you can see why we might be, you know, flooding the area or the research with more observational and more correlations. But you're absolutely right, Beth. Thanks for bringing that up. Yeah, it's tricky. That's why we all get to decide. You know, if we're going to do something or do an intervention, why are we going to do it? You know, and what's the research behind it? Yes.
Can you speak to the percentage of people who have Parkinson's that develop dementia?
I can't give you an exact number, but I would say, just in my, I would say about 50%.
And is there a particular name for that dementia?
Well, there is an interesting correlation between that sometimes and Lewy body dementia. So Lewy bodies are these little things that they can stain when they take a blood test sometimes. So yeah, that is a very interesting phenomenon. Yeah, yeah. But there is definitely dementia associated with that. And then again, you know, we're seeing, at least in some people that I've seen, a mixed presentation. Like, you know, they have appearing to have more Alzheimer's, mainly because they've had maybe a football injury or something like that, or played football for a number of years. Then anybody who's had that suspect for Alzheimer's, again, partly back to this question of when there's trauma to the brain, that's maybe when amyloid is released, you know, protected, trying to be protected to the brain.
Thank you.
Yeah. Yes.
So Beth McCann?
McCann, M-C-C-A-N-C-E. It was just in the Harvard newsletter, in the December Harvard medical newsletter. And you have to go online and take it, but it's actually been a great test.
And then if you wanted to have like an APOE or some other tests done, does a physician have to request them?
No, there now are, partly because consumers are now brain body health scientists. We now have consumer-driven labs, so we don't need a physician's signature. They don't take insurance, but you can get an APOE4. I actually use a lab called Empower DX, EMPOWERDX.org. And they are, they've been great. They have a saliva test that they do. It's $99 to find out. Most of my clients are opting for that. I have one client right now that is doing a blood test with just Adventist Health and doing an APOE4. And Medicare will pay for that. Yeah.
What was the website you just said?
Empower DX.
Is,
Yes.
is all this information information on your website?
A lot of it is, yes, a lot of it is. I have a web page, my homepage has a lot of resources on there.